Uh, okay, recording's in progress. Right. Hey, folks. Welcome and good afternoon. Just as a brief introduction of myself, my name's Ali James. I'm currently the head of physical therapies for the Aston Villa senior men's team. And yeah, my privilege to be able to present to you guys this afternoon with the brief being to look at acute management of pitch side injuries. I've gone down the route
Nice. What
really
did
of
you give him? Was it the wheelchair services?
oh, somebody's not on mute there. If we can just make sure all are on mute, I'm happy to take questions, but maybe not your Tesco's order. All good, fantastic. Okay, so we'll skip on. Hopefully, I'm sharing screen. Here we go. So look, guys, I just thought it'd be good to give you a little bit of an insight into my journey so far. Not just to give you a sense of my credibility to be able to speak with you today, but it's also nice to see somebody maybe at another point in their journey. And I'm very much don't perceive myself to be at the end of my journey. I still feel very motivated, very driven. I constantly looking at what my learning needs are and how they match up to what my sort of professional development goals are, and where I endeavor to either want to get to or how I want to deliver my role as I do it now. So me talking to you is me also talking to myself, and I think it's important to know where we come from, and especially as I think that my background and my development is very much an expression of sort of where I am today. And I'm very much a traditional physio, let's say, somebody that did an undergraduate physiotherapy degree, and after that went on to do his junior rotations in the NHS. And when I say I did it, I very much did it, and stayed as a junior for a good couple of years and worked around all the different domains from, acute trauma. I worked in intensive care. I worked on surgical wards. I worked in neurological rehabilitation, as well as doing all the outpatients musculoskeletal bits, and wasn't really in any rush to get anywhere, and just made the most of what those experiences are, because that's one of the amazing things for us as physiotherapists. We can find ourselves in all of these different domains, and all of the skills that we learn in these areas will stand us in good stead for the future. And I'll talk a little bit more about as I've become maybe more of a leader and a manager in sport, and I've done a lot of recruitment. And it's been interesting seeing the different paths that some people take. Some people go down a way of developing very domain specific expertise, i.e., graduate, get a sports job ASAP, and try and climb that ladder as quick as you can, which is certainly an approach, and it will certainly expose you to a range of scenarios and clinical cases which are probably relevant to the area that you want to work in. But what about when that person presents that day with that pathology or that issue that very, very infrequently presents in sport, or as masquerades as something? And because you've maybe not seen it in a different environment, it just means that you're biased in your clinical reasoning in order to not recognize that with regards to your index of suspicion, and then go looking at it. And I'm extremely proud of my NHS background, because I can say that I know what a poorly patient looks like. So when I talk about some of the scenarios today around people who are, looking at life and limb-threatening scenarios, as I say, I know what a poorly person looks like, and when somebody's going off. And often we can talk about our observation when we're in sort of immediate care trauma scenarios, and we can pay lip service to it. I'm looking at their perfusion, we might say, but what does that mean? And the reality is that seeing somebody on a hospital ward when they're in distress does give you some information, but sometimes actually we forget that even if you look at yourself when you're really, really ill, how do you look? You look a bit pale and a little bit clammy, and all of these signs. And this is what we sometimes see in our patients. And a classic example that I give is I've subsequently seen deep vein thromboses in the sports scenario, but when I first saw them was on surgical wards. And actually understanding what it looks like, again, enables you to have that as part of your clinical reasoning. So, hey, here's me doing my thing for the NHS, but as I say, very, very proud of it. And I think when I then progressed on into sport and started doing immediate care qualifications, I felt then having those more extended skills, such as auscultation, for example. I worked in intensive care for around 3 months, so auscultated many chests and had an understanding of the range of added sounds that you can get when you can auscultate, the positions that you can auscultate, and so on and so forth. So then when you're then talking about it in an immediate care sports scenario, actually you're not so daunted, because actually this is part of my skill set. And I'd say that that's not something that you would get by going very much down a domain specific route and avoiding that. That said, it's not essential. And as I say, I've probably recruited people in equal measure that have gone down both paths. But it's just about saying, irrespective of whether you do it as a junior, when you go down that road as a student, we just need to make sure that we give it the attention that it requires, because it will make us a much more rounded and holistic and effective practitioner that's able to take a multi-system approach to our examination and assessment, and ensure that we then don't miss some of these more subtle issues, which can start subtle and then sometimes become limb or life-threatening. So again, not to talk you through my CV necessarily, but yeah, I worked in the NHS as a junior and then as a senior doing some specialist orthopedics, which I really liked. And then after that, I did my master's at the University of Oxford in the science of medicine of athletic performance. It was essentially a sports medicine master's. And then following that, I did my manual therapy master's again, which I found was a fantastic step for me, because as well as having experiences and having developed a real scientific base to my knowledge, I felt still that I wanted to enhance my framework, my clinical reasoning framework, in which those different types of knowledge could sort of be underpinned, and I could then access it in an effective way and implement it when I was working with a patient or with an athlete. I did some work then in and around private practice and in sport before then fundamentally making probably my big career step into elite rugby, where I ended up being the head of medical services or head physio at Wasps Rugby. As I say, I was there for a decade. In that time, I did some consultancy with the national team, which I'm extremely proud of. And also along that way, from about 2014, I then became an immediate care tutor. So we'll talk a little about some of the qualifications that are out there at the different levels. And one of the principal courses I'm a tutor in and have been for the last since 2014. So there's my sort of other credibility piece. I now find myself, as the head of physical therapies at Aston Villa, following my previous club going into administration, which is another thing to consider when taking a life in sport. It is a volatile world. It's extremely competitive, and did I say it's also quite volatile? So having that grounding of your training, okay, and having taken a very systematic approach to one's learning needs and one's career development, and understanding that you've got the fundamentals in place to do whatever you need to do in any environment and in any sport, that can make you a very confident person if things then change at short notice, as they did with myself. So guys, when talking about immediate care and trauma care in sport and with us, and as I say, I had the privilege of working with elite athletes at international and at the sort of pointy end of sort of domestic and European sport. With that comes an incredible amount of responsibility, and we really need to be thinking about our scope of practice and our competence and understanding sort of what those sort of words mean when we're sort of encountering our care of these people. And again, this might then be my sort of disclaimer page, in the sense that nothing that I talk through today is going to generate any sense of competence with with you as a group. But what I intend to do is hopefully give some of you a bit of an insight into some of the approaches that are used when doing assessments in immediate care, and some of the tools that might be in our disposal to help sort of on day to day. But it's that having this understanding as developing practitioners around this scope of practice piece and that competency piece. And I haven't gone into it, but looking at around what our duty of care is towards the patients and the athletes that we encounter, and making sure that we've adequately assessed the risk and the benefit of the treatments that we're going to do. And not only that, the evidence that backs that up. So in the event that something was to go wrong, we can stand back and say, but I was adequately trained to deliver that skill. I've assessed the risk of what I was going to do. I clearly understand the risk and benefit of what I was going to do. And not only that, I've gained clear consent from the person that I was going to do. And hopefully with those things in place, and that's certainly not an exhaustive list, that in a court of law, if something was to go wrong, then we'd be in a position that we've covered due process. And these are some of the responsibilities that come with us being a professional, and no more so than when you're at the front line in immediate care. And this is where we may see some reasonably extreme life or limb-threatening scenarios. So with respect to that, and probably moving on to that sort of competency piece, well, how do we go about being able to demonstrate the evidence of our skills and our competence, and sort of formalizing that? And there are some sort of qualifications out there that we can do that can do that. Now, going on a 2-day course or a 3-day course, yes, may be able to give you a sense of competence, but it's also about understanding how you maintain that competence and how you maintain those skills. And we need to be quite structured and thoughtful around that, because again, you could say that you've got a certificate in your drawer of something that you did 6 months ago, but that doesn't mean that you've retained all of those skills, and whether it be the knowledge or the psychomotor skills that sort of come with that. But these are a couple of courses. You've got the one which will be your advanced trauma medical management in football, which is termed ATMIF. And then your pre-hospital immediate care in sport, the PHYSIS, that's the course that I currently tutor on. And my time now in football means that I'll be sort of navigating the ATMIF sort of journey as well. So, we couldn't be talking about trauma without having some fairly nasty images to just wake us all up a little bit. So hopefully nobody too squeamish, but these things do happen. And I've certainly seen in my time, some fairly significant injuries. But what I can say is that by virtue of being qualified and having a process by which you will assess these scenarios in a systematic manner, and in a manner where that you're going through a hierarchy of things to do, and when you've honed those skills and practiced them, when these scenarios present themselves, then actually all you're thinking about is process. You're not thinking about, gosh, that guy's foot looks like it's pointing in that direction. Actually, what you're thinking is, okay, there is some deformity. There's probably going to be some stress on some tissues. There's probably going to be some pain. From a neurovascular perspective, he may be challenged. And actually, we need to see whether we're in a position where we can create some normal alignment to offload the tissue, manage his pain, manage the risk to the neurovascular structures, and hopefully optimize the fundamentally a favorable outcome, because it's likely that they're going to need some definitive care. And I can safely say that most of the surgeons thank us very much when we do those interventions that we're sort of trained to do. But then, it's not about just sort of having those skills as you as an individual. It's really, really important to have done your planning so that you can work effectively as a team. And by virtue of some of the clips that I'm going to show you now being on actually online and recorded, tells you that this isn't always the case. And we can talk a little bit more after that in terms of how we can make it a little bit better than this. Let's hope this runs. This is certainly how we don't want it to look. This is one of my favorites. Unbelievable. Note the UEFA badges. That seems a common error. I think it's do no harm, isn't it? That we try to achieve. Anyway, folks, I hope you'll excuse me for that moment. But I think what it does tell us is that we're going the wrong way. There we go. This is probably more how we want it to look, and yeah, not just chosen this picture because I was in it, but hopefully, instead of everything else that was going on and that craziness, instead you should have a well-oiled team where everybody knows what they're doing and what their roles are, and you've got competence, and it's smooth and it's slick, and you've got the best interest of the patient at heart. And in the environment that I work in, we are on every TV platform. We're going to be on social media. It's going to be fans in the crowd with their cameras recording everything. And the expectation is that everything that we do should look professional and it looks slick and it doesn't happen by accident. And I think from an immediate care perspective, these are the fundamentals that you need to understand. It's not about just having a certificate and doing a 2 or 3 day course. It's understanding what you then do with that information. And often on those courses, it's understanding about emergency action planning and risk assessment and what that embodies, which is going to make you be part of an effective team. Let's try and skip on from there. Here we go. So part of that is very much risk assessment, okay? And so what is risk assessment? So it's about, an assessment of the level of risk associated with the actions and tasks that occur in your working domain. So, sorry, if I just click something, that means I've got stars behind me. Apologies, goodness knows how that's happened. So if I take my my setting, guys go out to training. We go games, we have away games. Guys will be in the gym, guys will go into the pool from time to time. We travel, we have times in hotels. There are lots of different scenarios which will bring with them different risks. And you don't always just take your trauma bag outside the training. You need to have it when you're on the coach. You need to have it when you're traveling. Maybe you need to have it in the dining room, when you're having lunch. And what's happening when the guys are in the pool? Who's supervising them? And who's going to raise the alarm and who's going to come there? These are things that we need to consider. So the assessment and consideration of factors that may impede effective immediate care and the team working in the event of an emergency. So what are the barriers? What are the barriers to us being able to deliver it? And that could be something like having the right kit. It's very, very reasonable. And I am very aware that working in Premier League football, especially working the games, we are so well resourced. We've got all of the snazzy kit. There'll be 2 or 3 ambulances there with paramedics, doctors, immediate care protection here, there, and everywhere. So we're very, very well resourced. And actually, those of you that might embark into the early parts of your career where you don't have those sort of support networks around you, might not have all of the kit. Things are a little bit more difficult. So consequently, how you go about risk assessing and how you go about doing your emergency action planning will be completely different, okay? And you need to make it relevant to your setting, relevant to your skills, and relevant to the sort of resources that you've got. Then you're sort of going on, obviously, from that risk assessment into your emergency matchday plan. So this is consideration of those risk mitigating actions to minimize those factors that may impede the effective immediate care and the teamwork in that emergency. So what's that? You find your actions, you find the risks associated with it, and then what are your mitigating actions going to be? And that is essentially, your risk assessment process. And once you've done that, if you've thoroughly done your risk assessment process and you've got your emergency action plans in place, you've got all the effective kit, you've got all the necessary skills, and everybody knows that means you can sit in the dugout and actually enjoy the game. Because if you haven't got those things, then you're not sat there enjoying the game. Instead, you're thinking, I bloody hope something doesn't go wrong. But actually, I don't sit there worrying about whether something's going to go wrong, because if something goes wrong, it goes wrong. And I'm actually there to help the athlete and help the athlete get the most optimal outcome. And that's my role. And we're prepared to do that. We've done our planning, we've done our risk assessment. And if it happens, then that's our job. That's why we're there. There's nothing there to worry about. Okay, so a little bit more detail around it. So, these written emergency action plans where, all team members, are going to know what their roles are, clear communication, clear understanding around roles, and it's backed up then by regular practice. We practice, certainly when I was at WASPs, we would practice our extrication and various different scenarios every home match day, because we were able to get there on time. My circumstances are a little bit different here at Villa. We tend to only arrive at the stadium 90 minutes before the game, so we're up and at it. So we use other opportunities to do our practice. And as I said, making sure we've got all of the appropriate equipment, which is aligned with our risk assessments, and also the local standards, because some of the governing bodies will have standards around, what you have to have, and nice clear lists, and and we can do stock checks, regular checks on dates, and so on and so forth. And again, some governing bodies may even have audits that back those things up. Thinking about the different venues that we might go to. You go to a different country, a different venue, then different risk assessments then need to be considered. And then again, what are our standards for our skills and our attention? So, the ATMIS and the FISIS courses that we've discussed. And then again, critical incident reporting. So what about when something happens? What about when something bad happens, or when something, there's an event? Then again, it's understanding these processes. A critical incident report allows us to reflect on our practice. These are all things that have been drummed into you in your training about being reflective practitioners. And all of these things will make us better and more sound, more safe, more reliable, and more consistent. And here's another bit that I just added to the end. For some of you sort of, budding sports practitioners or, future medical managers, it's about thinking, well, what happens after that? Right, okay. So even if you keep it simple, somebody tears a calf or tears a hamstring, what happens that? Okay, what do we do now? Right, we better find somewhere that we can do an MRI scan. Gosh, and how do we pay for that? And how long will it take for the report to get through? And who's going to read the report? And then after that point, if we need to see a consultant, who are we going to go and see, and how are we going to get there? And who's going to be looking after them? And these are all the fundamentals of medical management. So having reserved MRI slots for the day after all of games, and maybe reserved slots for within the week, or having relationships with your local, imaging providers. And guys, just to try and give you real life, and I think that's why Matt's invited me here. I'm at the front line, and I've been on the front line for a while. Being a good human being, having good values, being able to establish relationships, having empathy, having respect. These are all essential things for something as black and white as medical management. Because quite frankly, a lot of these imaging departments run at capacity. Find me an imaging department that has free spots. They don't. They're all free. There's waiting lists absolutely everywhere. So why on earth would they want to be on the beck and call of a medical manager at a professional rugby team or football team? There's nothing in it for them, because trust me, they're not all Aston Villa fans, and they certainly weren't all Wasps fans, especially in Coventry. But what you do is you turn up and you have a meeting with them, and you have a coffee, and you bring some things, and you just foster a relationship. And then they get to the point where they then become an extended part of your team. And they're not doing it because you're paying, they're doing it because they want to. They're excited about being part of a team and part of a winning environment. And they want to go the extra yard and stay behind an extra hour to do a scan, and maybe do a scan in their lunchtime. And I promise you, this is what medical management is all about. Yes, it's the black and white of the detail, But actually, remember, it's also about being a good person, a good communicator, being able to develop those relationships, because this is all developed around that. If you want a radiologist to do a report on a scan at 10 p.m., give you a call so that you can go and tell the manager in the morning. Trust me, they're not answering the phone unless you've got a relationship with them. And that's not about being sort of contrived or manufacturing relationship. It's about actually, putting energy into building these professional links. And it's just maybe an insight that may be obvious or maybe not. But I thought I'd sort of share that. Okay, so now to the nuts and bolts of it. I talked a wee bit about having a system, and that system being sort of fairly hierarchical, and it's there so that you address the most important things in the right order. Because let's say somebody's fallen over, they're unconscious, they've broken their ankle, and they've also now are not managing their airway because they've lost consciousness. Their ankle that's pointing at 90 degrees might look like the priority at the time. But the reality is the 5 minutes that you could be messing around with an ankle for somebody that can't breathe because they're unconscious and not protecting their airway, you've got a limb-threatening injury or you've got a life-threatening injury. So that's why the airway is at the start, and whatever you would put musculoskeletal injury under, it generally finds itself in E, but it's at the end, because the life is certainly going to be more important than the limb. And the reality is you'll get there quick enough. The amount of time that the limb not being perfused is not going to be that significant in the context of a primary survey, which in most instances you'll be through in a matter of minutes. And this is that hierarchy that I want to talk you guys through, because again, some of you may go down the road of qualifying and doing some of the more formal qualifications, or maybe some of you have done it already, and actually maybe hearing me speaking about it slightly differently might give a sort of greater insight, or maybe I might conceptualize a little bit differently, or if nothing else, maybe a tiny introduction. The first thing to remember is you have to not make another casualty, and that other casualty could for sure be you. And if you looked hard enough on YouTube, you'll probably find me running out into a pitch in a Premiership game up in Sale with a crazy South African trying to knock me over. But you've got to have your wits about you. And in that scenario, the ball had been kicked out. So really, once the ball's out of play, you should be okay to go. So as I started running, they then decided to take a quick line out behind my back. And then as I'm attending to the player, I turn around to see their hooker pretty much running directly towards me, because I think he wanted to try and get a penalty. And what he didn't know is that I used to play rugby for a living myself, so know how to drop my body weight and just defended myself, let's say. And yeah, there was a coming together. Nevertheless, I'm saying that example because we need to make sure it's safe to go on. And when you're in an environment of athletes, you certainly don't want to have yourself hurt or somebody else hurt, or and I'm talking about rugby or football, but we're talking about, we could be in any sport, couldn't we? It could be motorsport. So, going into the middle of the road, or cycling, going into the middle of the road, or equestrian with an animal that might be free. It just might not be an opportunity to go out. So being safe to attend is absolutely huge. So you need to assess the scene. It needs to be free from danger, and then you can be in a position to start your sort of evaluation. Now, I mentioned sort of catastrophic bleeding because that could be clearly a thing. Airway very much sits at the top of that hierarchy. But if somebody is sort of gushing blood out of a sort of a cut artery, then for sure you're going to compress and pack that. So that's like a slight disclaimer that sits at the top of the list. But where else we sit at the top, it's going to be airway, and that's going to be most important. And that's airway with the management of the neck, because some of the techniques that you can do to manage and help the airway could put pressure on the neck. So we need to make sure we protect the neck, especially if we're in a scenario where we've not seen the mechanism that's gone on. Many times I'll go onto a player in football and you can see he's been kicked in the leg, he's gone down, he's defended himself as he's gone down, fallen, managed himself, his head hasn't hit, Nobody else has hit his head. I know there isn't a neck injury. I do not need to stabilize this guy's spine. But there are instances where somebody might go up, somebody lands on them, and they emerge, and a player could just be there on their own. We don't know what's going on. For sure, I'm going to be immobilizing and stabilizing their spine whilst I then assess their airway. Breathing, of course, and making sure that people are adequately ventilating. The assessment of circulation and managing any hemorrhage. And then disability goes down to their neurological status. So have they sort of had a head injury or something along those lines? Because that can have a big impact on what we basically do with them. Because if somebody is not fully conscious, fully orientated, then they may not be able to tell you clearly or realize that they actually have an injury that you could exacerbate by moving them. And an exposure and environmental control means, well, like this guy here, he's out on the pitch on this looked like a dry day. I've got my shorts on. But if you're out there for too long, you could obviously get cold. And that's something we obviously need to consider, but also need to consider our exposure of that athlete to be able to assess them fully before we move on. Okay, so let's talk a little bit more about airway. So as we said, we're gonna protect the C spine, and we've got some different ways of doing that. Is this going to allow me to click back? Yes, it does. So I'm on my way to doing an anterior hold here. So I'm going to put my sort of like a 3-point stabilization. I'm going to put my hand on his forehead, left hand, put my right hand on his chin, and then I'll eventually put my right elbow on his chest, and I'll hold him still. And that will enable me to then speak to him and find out a little bit more about what's going on. So I'm now looking down at his face. I can look into the oropharynx. He can see me, we can make eye contact, and we can communicate. If not, I'm also creating space for somebody to come in there and potentially stabilize his neck from above. And that person would lie on their stomach, hold their head with their hands, not sort of blocking their ears, and then they can then stabilize for me to be able to then continue on and do the rest of the assessment. Okay. So as I said, look, listening and feeling. So looking, okay, there's various things you can look at. Is his chest going up and down? You can look into the oropharynx. Are there any obstructions? Is there a gum shield? Are there any teeth? Is there any blood or fluid or anything like that? You can enhance the looking process if you're not sure, especially if you're listening and hearing something of concern. So the things you might hear is sort of like snoring type noises. I'm not sure if anybody's seen anybody faint or something like that. Essentially what happens is the sort of soft tissues, basically your tongue, can sort of go back and occlude that airway, and then you sort of then do this sort of snoring sound, what for sure you've all heard, and that will give you an understanding of, is there an airway obstruction here? Or sometimes you might hear like a gurgling sound, so that might let you think, okay, there could be some fluid here, whether or not they've vomited, possible, okay, and it could be something that's come up, and clearly if that's the case, then you'd want to do something about it. Just to give you a little bit more detail on it while we're talking, if somebody's got some fluid in the back there, then you wouldn't want to necessarily immediately open their airway, because they may then aspirate it. Okay, so I know you all know the implications of aspiration. So in that instance, you would use your pen torch, and we have suction devices where we can look and suck away, get the fluid away, and then we can then assess the airway a little bit more, or try and support the airway. And there's a couple of techniques. I'm sure a lot of you have encountered sort of CPR and basic life support, where you do a head tilt chin lift in order to open the airway. But clearly in the instance of someone that we haven't seen the mechanism, and maybe they're unconscious and we don't know whether they have a neck injury, we're not going to want to move their neck. And there are techniques such as a jaw thrust, which will allow us to sort of don't know why it's doing it, enable us to keep their head still whilst opening that airway. So there's different techniques that allow us to sort of protect that. And I obviously mentioned suction, and the McGill forceps are a tool that you can use. Again, if you're looking in their mouth, if you can see something, then instead of putting your fingers in there and getting them bitten off, then you can use McGill forceps. Okay. So breathing is going to be the next assessment, and we're going to want to know about respiratory rate. Okay, everybody knows that. is important. And when somebody's in a level of distress, then what do we see? We see a little bit more of this, an increased work of breathing, okay? All of these words and terminology that we remember from our respiratory modules and so on and so forth, all applied now. It's all relevant. It's all going to make us better immediate care practitioners. Respiratory rate, hand on the chest, how many breaths are they sort of taking in a minute? An expansion, we're going to put our hands on their chest again, feeling if they're expanding, and that allows us to know that the mechanics of the chest are working. We talk a little bit later around sort of spinal injuries where those mechanics can be sort of impeded depending on what the level of the injury is. But knowing those mechanics, knowing that there hasn't been any rib fractures, knowing that there aren't any pain, and then again we can enhance that assessment using auscultation. Okay, is there good air entry? Are there any added sounds and percussion notes? Are there resonant or dull percussion notes? And as we know, we can have injuries to the chest, which involve them maybe filling with air, maybe in the sort of pleural space. And we can have scenarios where they maybe get filled with blood. And then so there's a difference between whether those percussion notes, that's when you tapping on their chest and making the noise, knock, knock, knock. And it may be a resonant noise or it may be a dull noise. Dull would obviously tell us that there's some fluid, give us an index of suspicion for what's going on. Circulation, clearly you need to check that there's sort of no signs of external hemorrhage, which we discussed, that color, which we discussed earlier, about that perfusion of the patient, of the athlete. What does that poorly person look like? They look pale. What does that tell us? Blood's being shunted somewhere else, or the blood isn't there. Okay, so that's an issue. Or they're going off, they're having some sort of autonomic response. It tells us about them. Pulse is going to be the fundamentals of it. Do they have a pulse? Very, very important, because clearly if they don't have a pulse, you need to double check and feel their carotid pulse, or you're going to be in the realms of sort of, basic life support for somebody that's in a cardiac arrest, okay? And then there's areas of potential internal hemorrhage where you can check whether it be the lungs or the abdomen or in and around the pelvis. And these are things that you sort of can have a look at. And we talked a wee bit about disability earlier. And it's basically to see whether somebody's alert. If somebody is alert, then they can tell you a little bit more about their pain, and you can make some more informed decisions about what you're going to do with them. And there's different ways in which we can do that. And there's a few sort of scales that we use. And in sports, certainly on the field of play, we use something sort of ABCPU, okay? And that's letting us know whether they're alert, whether they respond to verbal stimulation. If we think they're confused, okay, so they might be responding verbally, but it might not be appropriate. If they're responding to pain, or if they're unresponsive, and have they had a head injury? And if that's the case, getting a marker of their neurological status is obviously going to be extremely important. And knowing, and a more detailed assessment of that would be the Glasgow Coma Scale, which I'm sure you've heard of. And we talked a wee bit about exposure, okay, considering the weather and the temperature. And it's also an opportunity to do a systematic top-to-toe check. And that's where you'd be picking up your musculoskeletal injuries, okay? And at this point, again, exposure is where we'd be thinking about extricating the patient, whether it be to an ambulance. And have we called an ambulance? It's certainly something that we're most likely to be with somebody with any life or limb-threatening issues, or whether it be going to a medical room if you have one to investigate further. Okay. I've sort of chatted sort of pretty non-stop for a wee while. Can I just check in just to see whether anybody had any questions or comments at this stage? Put your hand up, take yourself off mute. I'll give you a couple of seconds, and if not, then I'll plow on. It's good to see your faces, that people aren't falling asleep. How was it, Alice Reed? Is it okay so far? All good? Fantastic. Well done. Okay. So worst case scenarios in sport, okay? Is it an ACL injury? I sometimes hear this talked about, this is the worst case scenario in sport, 7 to 9 months out. I think in this series, you might have some talks around rehabilitation, and people will talk about worst case scenarios in rehabilitation, making sure that from a metabolic and sort of locomotor perspective, that people are being exposed to what they're going to get hit at in a game. You get these really tough passages in a game where somebody's coming back from a hamstring or a calf or an adductor. Jeepers, you need to make sure they've been exposed to that. So when they do it in the game, they don't have a recurrence. These are some of the things we talk about, worst case scenarios in sport that we need to prepare our guys for. But for me, no. Worst case scenario is this, okay? And this happens. And when we're talking about risk assessment and when we're talking about emergency action planning, we want to know that if this happens to one of our athletes in any of those settings, training, physio room, gym, in the pool area, when they're dining, or in front of millions of people during a Premier League or Champions League game, we better be prepared. And this is massive for us. And even myself, I'm an immediate care tutor. I work with A&E consultants and sports physicians and very, very smart people. We put a lot of work into this year in the minute detail, because that person on the pitch is our responsibility. Okay, we have a duty of care to them. And I try and think about it in terms of if that was one of my children, even if we need to conceptualize this anymore. And we've looked into so much detail this year that actually, believe it or not, some ambulance services do not administer cardiac compressions whilst the patient is in the ambulance. There's been some scenarios where the ambulance has been driving fast and the unrestrained, i.e. you haven't got a seatbelt on, paramedic has been injured when an ambulance has then crashed. So there is some notions around some standards written in to some of the ambulance services, and they're divided up regionally. So you might have a West Midlands or East Midlands and so on and so forth, where they do not. And there's also some evidence to suggest that actually when standing next to a bed in an ambulance, whilst the ambulance is moving, they actually can't even administer effective cardiac compressions. So we need to know that information as part of our emergency action planning, so that we know that from where we assess the patient to their definitive care, that there's no break in that care. Because what is going to give us a good outcome in the scenario of a cardiac arrest? It's going to be good quality, uninterrupted cardiac compressions, and it's going to be shocking as quick as possible. And I'm going to come back to it. We don't want to interrupt our care. So we could be doing all the snazzy things. We think we're so great, and we've got sort of eye gels in with bag valve masks, and we're pumping away. We've got our Adidas kit on. We look amazing. And then they're going to then put them in an ambulance and not deliver compressions. Wow. So we've had to consider this. And then some of the guidelines, we've looked at some of the guidelines, and guys, you know, you are being taught to be critical thinkers, critical learners, to absorb and consume knowledge critically. Anything that anybody says to you, anything that you're reading or reviewing, review it critically. So when we review, let's say, sporting standards that have been written that are saying you extricate a patient after 3 shocks, why? And to where? And what happens next? Yes, we look at the guidelines and we scrutinize those guidelines and we use those as standards of practice, but we can go over and above that. We can be critical in terms of how we look at it. So then we put then processes in place. So how we will not leave until we know that we're going to be able to deliver uninterrupted care. So we will wait for an automated device to come to us. And then with that automated device, cardiac compressions will not be interrupted. Or we make sure that we've got an ambulance team working with us who will agree to continue care on the way, or we at least know the time difference between us and the hospital. And this is just me giving you an example of this worst case scenario, but also understanding that we can't just go through the motions with this. This is real. This is very real, and it doesn't matter whether it be at your local team or in the Premier League and Champions League or international sport. You know, we need to think critically about what we're doing, take responsibility for our plans, and make our plans specific to what we're doing. Okay, so basic and advanced life support. So this is, you know, talking about worst case scenarios, cardiac arrest and not being prepared, that's an even worse case scenario, okay? If it happens, you know, goodness, you know, it's not going to be great. but let's be prepared. Let's have done our risk assessment. Let's done our emergency planning. Okay, guys. So I've not talked you through the nuts and bolts of 2 breaths of 30 and how hard you press. This I've given you some on the ground detail around how you will apply those very basic things. So spinal injuries are absolutely a thing. I've fortunately not seen anything of significance, but for sure spinal boarded a good few who may have had a suspected injury, and the mechanism of injury is going to be the thing that's going to be a big concern for us. So axial loading with compression, okay, this sort of hyperflexion, hyperextension, excessive lateral flexion or rotation, and I suppose traction, depending on what the context is, but not very common in sport, of course. What could happen? Vertebral fractures, fracture dislocations and subluxations, or acute prolapses. And what are the signs and symptoms? Okay, so central neck pain or back pain, paralysis, numbness, paresthesia, and obviously respiratory difficulties could be a thing. So this is a way of just illustrating it's the same process. Doesn't matter what it is that we're encountering, it's the same process. Make sure it's safe to approach. Is there any sort of catastrophic bleeding that we need to manage? Manage that C-spine, of course, and also manage that airway, because somebody could well be unconscious and not managing their airway. We then need to assess their breathing, circulation, their neurological status, and their exposure, all extremely relevant in the context of a spinal injury. So it's a great example of how we apply this systematic approach. So airway maintenance with C-spine control. So in a suspected spinal injury, as we said, we need to inline stabilization while the athlete's being assessed. And instead of doing a head tilt chin lift to open the airway, we would do this jaw thrust. You can see on the image, somebody above stabilizing the head, somebody from below bringing that jaw forward and opening that airway in a safe manner. So what about breathing? Okay, same assessment, respiratory rate, looking at expansion, and as we know, injuries to the upper thoracic or lower cervical cord can result in paralysis of those intercostal muscles. We said this, resulting in respiratory difficulty and diaphragmatic breathing. And then high cervical cord injuries could clearly paralyze your diaphragm as well. And that's going to be significant respiratory impairment. This is something that needs to be assessed and something that would need to be supported in the manner. This is a bag valve mask. Circulation. So in the context of a spinal injury, the neurogenic shock is a thing. Okay, so you're looking at the sympathetic nervous system being damaged, that having an impact on one's vascular tone with peripheral vasodilation and sort of pooling of the blood. And obviously with that sympathetic nervous system, obviously controlling your heart rate, which would be your means of compensating, then again, that means of compensating is then going to be potentially taken away in the context of some spinal injury. Okay, and then how are we going to manage that? Then yeah, those with those advanced skills would need to be careful with their fluid replacement. You'd also really need to not assume that in these scenarios that it is neurogenic shock if somebody is displaying signs of shock, because there could be other injuries or other areas of occult bleeding that clearly you'd need to assess in a formal manner. And it's just thinking about if somebody's in a state of potential neurogenic shock, then that would maybe manage how you might go about your extrication. So you'd want to be avoiding tipping their legs to exacerbate that pooling and potentially creating a risk of further decompensation of the patient. Oh, have we gone the wrong way? No, I think we've not gone the wrong way. I've just maybe used the same picture again. Apologies. So, if somebody is alert or not is absolutely huge in the management of spinal injuries. You need to be alert to be able to clear the spine. Is essentially it. If they're not alert, it doesn't matter if they're not telling you there's any pain or whether you can't assess them fully. You're not going to clear the spine, and you're going to have to do immobilize them. And again, as part of that neurological assessment, you're going to be looking if there's any sensory deficit in the ways that you guys know. It's simply, looking at sort of dermatomes and a motor assessment, which you could do based on myotomes. And that could give you a bit of a baseline of what's going on. Suspicion, increase that suspicion that there could be some damage, some neurological damage. And also, that baseline allows you to then feed that back to the paramedics so that when somebody gets to the hospital, they know, oh, okay, they were there then, and now they are that now. Let's say there could be some swelling, for example, and actually as that swelling goes down, you could see a return of function. So this is JR Kaut's guidance for spinal immobilization. I'll talk through it. So potential spinal injury, we talked a little bit about the mechanism of injury. Is the player conscious and alert and able to, follow and cooperate with the examination? If no, you're going to immobilize. Okay, are they under the influence of alcohol or drugs? You'd hope not in sporting context, but if they are, you're going to immobilize. Do they have any spinal pain? Okay, and you're looking at central spinal pain with this. Okay, so it's not sort of that muscular type pain. That might be more lateral, central spinal pain. And you would confirm that on palpation. Do they have any neurological deficit? You know how to assess that. And do they have any distracting injuries? You guys know about gating theory and the sort of transmission of pain. So clearly somebody has pain somewhere else, it's going to affect your perception of that pain. And clearly in that presence, you wouldn't be able to assume they don't have a neck injury or a back injury. So you would thus immobilize. So how do we do that? We got these, sorry for the shouting outside, I don't know if you heard that. We have these split boards that we can use, and a little bit more advanced than the old sort of spinal long boards, because now you only need to tilt the patient 15 degrees, just enough to sort of slide it in one side. You can see it's split. You slide it in the other side and then click 15-degree tilt, and you're going to use 3 people on either side for that, with somebody on the head stabilizing, and they're going to move. You apply the blocks, straps on the body, strap the blocks on, and then you're nice and stable. You do a transfer onto a bigger extrication device, and then sort of away you go. All right, folks. So maybe what's more common is the musculoskeletal injuries, but as we talked through those sort of that hierarchy of assessment, this is the sort of thing we're encountering later on in our sort of primary survey in that E. This is where within E, once we've gone through, made sure the airway's fine and the neck is stabilized if required, breathing is fine, circulation's fine, and disability is good, we're going to then do our top to toe, and that's where we may find our musculoskeletal injuries. And this is your bread and butter. Look, feel, and move assessment will tell us what's going along. We're looking for anatomical deformity and pain. Is there any hemorrhage, swelling, tenderness on palpation, crepitus, or any neurological compromise? And again, our big concerns will be any effect that could have. As we know, we've got neurovascular structures that run alongside all of our joints and limbs. So if they're broke, then we can have some issues there, and that's something that we clearly need to assess, and very much are potential complications of musculoskeletal injury. So again, another little algorithm here that's been published, where again we look, feel, and move, and no obvious issues, and you move on. If there is something, if there's a wound, then clearly you're going to do something about it. And generally, we're going to manage those with sterile gauze. If there's a deformity, okay, what's their vascular status in the leg? We're going to be looking at the various pulses. All the basics again, guys. Your anatomy that you learn, or that insignificant vascular and neural anatomy. Think, oh gosh, I won't bother learning that. No. It's worth learning it because it makes these things easier. Assess their vascular status and the pulses in the foot, the various different things. So whether it's normal or abnormal, that may depend on whether you need to splint or realign. And then again, making sure that we're sort of reassessing circulation and neurological status after everything that we've done. A very odd thing that we always have to teach people, that if you were to, if somebody had a pulse, but it was not in alignment, there would clearly be an indication to still realign the limb because of the pressure on the neurovascular structures, pressure on the skin, and pain. But what if you realign it and you lose the pulse? Then you need to then put it back, and you wouldn't clearly just wrench it back. You just gently move it back a little bit until that returns. And I always hope that scenario never happened to me, and it certainly hasn't. And after that, you'd clearly be looking to repatriate somebody to hospital. So that's it from me, folks. A bit of a whistle-stop tour through the management of pitch side injuries. We focused a little bit more on more life and limb threat, but also the context of where that sits with us as professionals in sport, and some of the detail that we encounter to enable us to be able to deliver our work at a high level, but consistently as well, is a big mantra for me. So thanks for listening. I hope that was of some interest and of some insight, and I'd welcome any questions.
I'll just say a massive thank you to Ali. That was brilliant. Really appreciate you taking the time to chat to us, because I know you're a very busy man. So yeah, has anyone got any questions they'd love to ask Ali?
I got a quick question. I was just wondering, I know you spoke about certification from the start. I know I was looking into it last year in regards to getting certified to obviously be in sport. And me and my buddies, we kind of looked at the cost of it, and it came out to be quite a bit. How did you manage with that? Because I know tuitions and all that stuff, and adding up all of that versus like just life expenses and the cost of those certifications. How would you go about managing that? Did you have like your teams or whoever that you were employed by pay for it, or like how would you go about moving forward with that?
Yeah, so I think I've generally been in a privileged position whereby the teams that I've worked for have paid for it. So that's more or less a full stop. But what I would say is I've seen practitioners that have paid for it themselves, and I would say it's a good investment. I believe that in many of the programs that you'd maybe be engaged in at undergraduate or postgraduate level, some of them have some exposure to sort of immediate care education. So I'd engage in those fully and get the most out of those things. So get the most out of what's out there for free. A lot of the work is very, very theoretical, and a lot of it you'd probably be able to access online. World Rugby will certainly have some online resources that you could access for free, and they're things that you can really learn in detail before you then consider going and getting the certificate, which is fundamentally that level of competence that some of the teams will want to know. And again, it will give you that sense of, it will have an exam in it, so you get a sense of at least instantaneous sort of competence for that moment. So yeah, my club's paid for it. When I was the medical manager at Wasps, we had an intern that literally emailed us and said that he was a qualified physio and he had his immediate care qualification, the right one for sport. He came in as an unpaid intern, and then when we had a vacancy because somebody left at short notice, he stepped up. He was ready to go. He had his qualification, and his investment absolutely worked. And he's now, I think, working in F1, doing very, very, very well, having sprungboard off maybe his work that he did quite early in his career at WAS. So I think make the most of exhausting relatively free resources. And then once you've exhausted them, and by that point, you'll probably be at a point where you're going to be able to look for the experiences that you might need that will require a qualification. And at that point, if the club that you're working for isn't willing to pay for part of it, then I would maybe consider the investment. I hope that answers the question.
Yeah, that did. Thank you so much.
I've just put the link to World Rugby into the chat as well. So if anyone wants to look at that, because that is
brilliant.
That is good. Anyone else? Any other questions for Ali? There must be one.
Don't be scared. And again, it doesn't have to be about immediate care. It could be career-based stuff. I tried to put that slide up at the start to talk a little bit about my journey and my pathway. So if people know the journey that they want to go in, and I might have any insight to that, happy to answer any questions around that. But otherwise, if everybody's just ready for their supper, then that's also cool.
Go on, Victoria.
Hi, I just had a question about kind of like coaching and like players dynamic when you're dealing with those like high risk situations. Obviously, I've heard some things about sometimes players can like get kind of in the way when, you know, their teammate goes down. How do you kind of create that environment of like respect between the players to make them understand that like you like are taking care of them and that they need to also give you the space to take care of them, but also the coaches, because sometimes I've had experiences with past experiences of mine where coaches can sometimes they question your decisions, but you know, how do you talk to the coaches as well as the players to make them like, you know, how do you build that relationship in that sense?
That's a great question. That's a fantastic question. That's a real thing. As you were saying that, I had this sort of flashback of coaches shouting in your ear, because often we might be mic'd up, shouting in your ear as you're working. I've had many coaches shouting at us not to go on. A lot of you will probably remember the famous sort of thing is Eva Cañera scenario at Chelsea, where she went on to a player that maybe was, and this is the trouble in football, right? The footballers are tough. It's a sort of they're misrepresentative if we think they're soft. I think it's just gamesmanship when they go down, and she hadn't perceived maybe that there was an element of gamesmanship, or the player might have been injured and the manager just perceived it, went on, and there was a really big bust up. So how do I answer your question? You can educate the players. You know, I'm big on sort of pre-season presentations, just outlining what my service is going to be and what my expectations is going to be of them. And I would just have a slide on that, say, guys, you know, depending on what the sport is and what the rules are, and you've been able to enter the field of play. Football's very restrictive, rugby is very loose. And then just say that, you know, this is what you're going to do, this is what it's going to look at. Please don't touch your, you know, ask them not to touch the player, because, you know, you might think you're helping, but you can be harmed. I'll get there. Guys, please let me know if you've seen something that I haven't seen, call me on and I'll come. You know, that sort of stuff. So engage them and empower them a little bit in that process, rather than just tell them to get out of the way. Relationship with the coach is absolutely huge, and maybe just being proactive about saying, what do you want from me? And have, you know, I'm sure you've worked with lots of physios before. What is it that you don't like to see? As you know, I'm going to want to go on and help, but if there's any way that I can do that, which is more so meets your expectations, then let me know. But if I see something bad, I'm gonna have to go. But let's work together, seek feedback as well, let them shape you. I've learned, I'm not going to say as much, but a lot from coaches about being a performance practitioner, huge amount, because so much of it is around communication, so much is about relationships, so much is about meeting expectation, understanding expectation, having empathy. And you can only do that by having a relationship and engaging in those conversations at the right time. So it's a fantastic question. I hope I went some way to answering it. If not, then please rephrase it, and I'll happily expand on that, give more examples.
No, thank you. That was really helpful. Thank you.
Great.
Anyone else? Go on, Alice.
Yeah, I was just wondering what you thought were the biggest differences between working in football and then working in rugby, and sort of how you dealt and adapt with those.
Great question. Can I ask you what you think the differences might be?
I mean, the obvious one that sort of shows you in your face would be the severity of the injuries you'd imagine, like the contact
Okay.
from the rugby.
Yeah.
I think that would probably be the biggest one.
Cool.
But I don't know if there were any sort of insider ones, or like dealing with it behind the scenes that there might be.
Cool. Okay, cool. Interestingly enough, when I showed the pictures of those nasty pictures of injury, I think they were all football examples. There was no rugby examples. So actually, severity isn't necessarily, I would say, frequency rather than severity. Footballers get some nasty injuries, especially lower limb. Maybe not so much spinal stuff, but fortunately spinal stuff isn't that frequent. So I wouldn't say severity, but I'd say frequency. I believe the data in rugby tells us that I think 2 time loss injuries per game, which is incredible. I think somewhere in and around 1 concussion per game, incredible. The frequency of injury in football is so low. I have been 2 or 3 games in a row and not gone on the pitch. In rugby, I never did it, but I think some physios had tracked themselves on GPS and were covering an incredible amount of space. So frequency of injury and also our behavior on a match day. I sit in the dugout, don't move. In rugby, you track, and you're allowed to. The rules allow you to track and allow you to go when the game has stopped. So that's a big difference. The other nuts and bolts are much the same, right? So injuries are injuries, and acute management is acute management. Intermediate care and loading is much the same. So I'm now going to answer your question in a little bit more detail, which might give you guys a bit of a sense around how you develop as practitioners. The first one is not about that, but it's about some of the nuance of football and rugby and the differences. So one misconception, footballers aren't soft. They're really, really tough. What they get paid is in the public domain. So people that get paid north of £100,000 a week, okay? So you don't get that if you're soft, okay? The pyramid of football, the base is so broad, and natural selection is just so competitive that you can't get there unless you're soft. And then the other thing is, because the game is changing, and with sports science boom and around how the game is played from a physical perspective, and you'll hear things around these luxury players, not these just solely technical guys, not really having a place in the game anymore. That's a thing, right? You watch Liverpool. We played Liverpool a couple of weeks ago. They were unbelievable. And the thing that was so unbelievable about them was their physicality and their speed. And they just press again and again and again. And these guys will cover like 12K a game. And, we're talking multiple high-speed efforts and sprints and intensive loading into acceleration and deceleration. And the workload that they're getting through is absolutely incredible. Guys with VO2 maxes of, approaching, 70 mils per litre per minute. These are fit, powerful guys. So if you are just a technical and you're soft, then forget it. I don't think there's a place for you in the game anymore. And I'm trying to wonder why. I watched football over the years, and there were these legends of the games many years ago. And I think there's just not that many of these just standout, incredible stars, but lots of, so I think the game has changed a little bit, but I've digressed a little bit. I was going to say about football and rugby. One of the points is very cultural, which is really, really interesting. Rugby is incredibly homogenous from a cultural perspective. So they're either from the British Isles, they're all the same, okay? People from the British Isles culturally are the same, okay? Or they're from Australia or New Zealand, they're the same, okay? Or South Africa, guys, they're the same, okay? Speak the same language, eat the same food, okay, yeah, fine. They might call, jelly jello or whatever, peanut butter, call it something different. It's the same stuff, okay? The French don't really travel, although they play rugby, they don't travel. So we don't work with them when we're here. And in Europe, it's sort of, yeah, okay, Georgia they play, but they go to France, they don't tend to come to us so much. So culturally, it's homogenous. In this team here, we've got Argentinians, we've got Brazilians, we've got Colombians, we've got Spanish, we've got Portuguese, we've got the sort of Central Europeans, we've got the English, it is so culturally diverse. It's incredible. And that's one of the things you said, made a reference to some of the subtle things that you might not think of. It's incredible. And the notions of these footballers that are uneducated and aren't smart and intellectual, forget it. Incredibly well educated, especially the Europeans. We've got guys that speak multiple languages. We're talking 4 languages like that for fun. Like, I speak reasonable French. I'm pretty well educated. and you just feel completely ignorant around some of these guys that are just reeling off multiple languages. Absolutely incredible. And so that was that. Okay, so subtle differences, but I would say that's the most significant, because if you're from Spain and you've been treated by Spanish physios your whole life, their expectation around treatment is different. And because we're different, like us sort of, and I'll talk a little bit about how maybe I don't know what we'll call ourselves, English type physios have gone one route, because other countries are different. You know, go to America, you've got physical therapists, you've got athletic trainers. It's different. Okay, it's different in different places. So these players have different expectations. You know, I played professional rugby, and so I had a common ground with everybody that I dealt with in rugby, and could have the pitter patter. I'd been in the dressing room, I'd done the games, I've been to the place that I knew everybody and all that sort of stuff. Come here, limited common ground. So it's a great challenge, and really interesting. So how do you make that transition? It's about the fundamentals. Okay, fundamentals of physio need to be rock solid. Okay, and then the fundamentals of being able to analyze, again, if you're going to be a sports practitioner, a top level sports practitioner, then the fundamentals that allow you to analyze movement. Okay, so the kinematics of action. Okay, so in rugby, what directions do they run in? How many times do they decelerate? When they change direction, how do they change direction? Is it a 360 game, or is it a more linear lateral game? And understanding those movements. Okay, then it's about thinking then about, and obviously rugby's got the whole contact piece, which football doesn't have. And then you've got the metabolic side of it. And, you know, where do they sit from an aerobic perspective, anaerobic perspective? And then being able to sort of then analyze and break down the needs of the athlete and the physical determinants of that sport and what they're going to need to do. And then you can tailor your rehab to that. And I'm sure you'll have these sort of other presentations around that space, whereby you'll reverse engineer your rehab. So you'll look at what can they do and what the parameters of what they can do. And then you gradually work back from that. And that's how you sort of build your rehab. So how did I make the transition? By having good fundamental skills, and being able to analyze the sport, analyze the needs of the athlete, and being able to deliver that. And maybe, having good communication skills, having empathy. I'm a manager, I sort of manage a team, so I have a lot of management and leadership skills, and that's very transferable. And interestingly enough, you know, we have a philosophy of having a very diverse workforce. So we've got a diverse workforce that have lots of skills in areas that if my skills aren't there, then we have somebody else that can do that. And if somebody else needs skills, and so on and so forth. So the diversity of your workforce enables us to reflect the diversity of our playing group, where in rugby, you didn't have to have a diverse workforce because everybody's the same. That's a bit extreme,
really
bit extreme, but more or less.
Thank you.
My pleasure.
Conscious of time, is there one last question that anyone would like to ask Ali before he goes? Anyone? Cool. All right.
Excellent.
Well,
We did well.
Can I get everyone just to say thank you to Ali, because you've been fantastic, really insightful, and definitely seeing a different side, I think, which is really great for the students to experience that. So if everyone can just say thanks to Ali for his time, and wish him luck as well. So I believe you've got a fixture coming up as well.
Yeah, Chelsea away this week. They come thick and fast. Always need plenty of luck. Hey, look, guys, from me as well. Thank you for having me. Thank you for attending. Hopefully, we had a reasonable attendance. Hopefully, it didn't keep you all too long and bore you too much. But no, it's as much of a privilege for me to be asked to come and to be able to present some of my insights. So I hope that it was informative, and I'll know that if I get invited back next year.
Thank you. Thank you very much. It was very useful.
Thank you very much. It was really, really helpful to learn from you.
Oh, great.
Thank you.
Thanks, guys.
All right.
Brilliant.
Thanks, everybody. And I'll stop the recording now, and I will see